individual presents with hypercalcemia, calcium of 12, creatinine of 3.6, acute renal failure, and actually relatively mild anemia with the hemoglobin of 9. Found to have a 6.2 gram IgG kappa paraprotein. A bone marrow biopsy confirms 90% involvement by plasma cells. Molecular analysis confirms a deletion of 17p and loss of chromosome 13, and imaging confirms lytic bone disease. So diagnosed with IgG kappa myeloma stage 3. So here's a series of questions that we have, and maybe the two of you could just give your input on these questions. So, Ravi, what would you start this patient on as initial treatment? Let's, I guess, presume that he would be a transplant-eligible patient since he or she is 54.
Yeah, so I generally am favoring the use of Kyprolis-based 3-drug regimen. So Kyprolis Revdex is something that I would probably start this patient on, but I do that irrespective of the cytogenetics. I know that the Mayo Clinic paradigm suggests using the cytogenetics to decide on the induction. In my practice, it's not something that I look at induction. It's more for the maintenance phase that the cytogenetics factors in.
So there's some practical issues here. This patient not only has high risk, he has a pretty high tumor mass as well. And of course, he presents with cast nephropathy. It's a real issue. The way it works in our hospital, these patients get admitted, and once they're admitted, we can't get them lenalidomide. The ability to get lenalidomide prescribed in a hospitalized patient for us is zero, so we can talk all we want about giving them len. You can't get them len. We would certainly use carfilzomib in a circumstance like this. Dara would be interesting. I'd almost no possibility I'd get reimbursed for it. And so we'd probably end up with carfilzomib, cyclophosphamide, dexamethasone for this patient.
I would agree. I think that I would say that in the hospital, certainly it's very challenging. So KCD is something we do frequently as well.
So in phase 3 trial, trust that phase 2 data.
Sure. Yeah, I know that it is, that's why I said during my talk that it is a thing that there's no agreement on. I think that the data is small. It is also, you have to give 18 cycles to get those results. In my own practice, I feel that it is not any worse, at least in terms of the efficacy, but also what drives my use is the tolerability. I know that some people have some concerns about cardiopulmonary side effects, and the French certainly have had some concerns about it from their trial. But as I indicated in my talk, I have not seen any noticeable problems over and above what VRD does. And certainly that Velcade neuropathy, you can give it once a week, you can give it sub-Q. It is there in the majority, and it just is what I hate to see.
Lord, this is a ridiculously practical question, but on a patient like this, don't you ever write a outpatient lenalidomide dose and then let them take their home supply?
So we have complexities with that because according to our rules, the drug has to be delivered to the patient's home. You can't deliver it to a hospital or a hotel, which is a common issue at Mayo, particularly with 14% international patients. And so it's theoretically possible to do the registration, which no one in the hospital knows how to do. This has to be done by a nurse brought over from the outpatient facility because no one has a clue how to do this. And so, yeah, maybe in a week you could get the lenalidomide there, but the fact of the matter is I'm going to give them 1.5 grams per meter squared cyclophosphamide IV within 3 hours of admission, because this business about the creatinine of 3.6 will haunt this patient if it's not reversible. No matter what you do, if you have persistent renal insufficiency, your outcome is going to be inferior. And the highest priority for this patient is get that creatinine down because it will dog all the rest of the course, which given this data is going to be relatively short, actually. And so it's tricky. And this business about carfilzomib, I mean, the reason there's a KRD, VRD trial is because nobody really knows. And until we get this phase 3 data about what the real carfilzomib signal is for the heart, and thrombotic microangiopathy and all that sort of stuff. Really, no one can answer this intelligently. We made our best guess, carfilzomib, but we don't really know. It'll be next year before we know, and it's unclear in this setting of newly diagnosed triplet-based therapy. We know that carfilzomib triplet better than doublet. We know that in the relapsed refractory setting, carfilzomib doublet better than bortezomib doublet. But in the newly diagnosed triplet-based, I don't know what the best treatment is. This is what I pick because I've got to do something.
So,
They're going to get switched over to lenalidomide, you bet. There's no question about that. Cyclophosphamide is, I think, inferior triplet therapy. And so once they're out of the hospital, they're going to get their Revacist and go forward.
so in community, this patient would be treated with Cyborg. Is it easy to give Revlimid in this kind of situation with renal insufficiency?
Yes,
It's easy.
easy.
Okay.
You just don't give the same dose. That's all. I mean, what is the toxicity in renal function? It's myelosuppression. Ooh, I mean, there's no one in the room that cares if the platelets are 30 or the white count is 1,500. We deal with that every day. Myelosuppression is not a barrier, and that's the primary problem with Lennon renal failure, is excessive myelosuppression.
Thank you.
Okay, so his initial treatment, which I presume occurred in the hospital, was that should be IV fluids, pamidronate, dexamethasone, and bortezomib, and that resulted in normalization of his calcium and improvement in his creatinine almost to normal to 1.4. And then his therapy was changed to Cybor D, received 4 cycles of Cybor D, and that was followed by a stem cell transplant, and he's now 45 days out from his high-dose melphalan autologous transplant, and there's a couple more questions as to how to proceed from here. What additional treatment should he receive if he has undetectable immunofixation? Should he undergo MRD testing? Should he have a second transplant because he's so young? And what about an allogeneic transplant?
Okay, so I would say that as far as the fish detectable abnormalities go, again, as does MRD, it is probably prognostic. Certainly MRD is. I don't know if anybody's looked much at the persistence of fish, but again, I don't use that in my decision making, but I can tell you quite a few other people, if they had been a different panel here, they would have said, we will increase our intensity of treatment. We need to get this patient to MRD negativity. They may be right, but we have no data to support that, and I can't, logically convince people. And the toxicity of increasing treatment is not trivial sometimes in these patients. As far as the issue of fish detectable abnormalities goes, also, as I mentioned in my talk, it needs bearing that not all fish detectable 17p or 414 may be bad. We're learning that it is maybe those who have biallelic problems that really are, the ones that are the worst actors. As far as the free kappa light chain goes, whether you're in a stringent CR or a CR, I would probably just move on to maintenance therapy. If you're less than very good partial response, I think that in most cases, if they are Medicare, it's not a decision that I am faced with because Medicare doesn't pay for tandems. For those who are younger, I have a discussion with them, but I don't force it. I do tell them that there is data to suggest that it may improve outcomes, especially if you have high-risk disease. But if a patient says, I've been through a lot, doc, I really don't want to go through another one, I will not push him.
Yeah, no, I agree with that. I think that the fish abnormalities for me might direct what the maintenance is going to be, but it's not going to affect these key questions now. And I think that there'd be a hard discussion. I'd have to find out what the first transplant was like. If the first transplant was 100% outpatient and the patient received 1 platelet transfusion, talking about a tandem I think is reasonable. If they spent a week and a half in critical care, went into atrial fibrillation, E. coli bacteremia, maybe not so much of a discussion. Well, that's always a driver. The patient's experience with the first transplant is a big driver of what this discussion is going to be like. This thing about allogeneic transplant is always a headache. I mean, you know what the most common cause of death is after allogeneic transplant for multiple myeloma? It's multiple myeloma. It's relapsed multiple myeloma because it's a crummy immunogenic target. That's the problem. We all know that allo is a good target for ANLL, and even though we don't do it anymore for CML and CL, they're great immunogenic targets, but myeloma is not very immunogenic. But you know this patient's not going to do well, and there's a 15% chance there'll be a 10-year survival with an allo transplant if there's a perfect match, not cord blood, not haplo. But so some discussion of allo. I actually don't like doing allos very often. We're very sparing with it. But you know that this is not going to go well for this patient. So some dialogue. And I would just parenthetically add to what Ravi said in the last talk. It's a bad immunologic target. Therefore, no surprise to me that CAR T works great for lymphoma and great for leukemia, and we're still in the woods looking for the light for multiple myeloma, and maybe it will come, and maybe not, because it's just not a very immunologically responsive tumor, because it's 15 years now since we started dinking around with dendritic cell therapy, vaccines, what we've been doing, and we're still not there.
How long would you maintain this patient on maintenance therapy? How long would you continue?
To progression.
That's what I do.
Do insurance companies give you any trouble? I mean, these drugs are about $15,000 a month, right?
So my maintenance for this patient would be bortezomib sub-Q every other week, and I have not had a single problem with reimbursement. It's wild, and I'm assuming since bortezomib will be generic shortly, that will become less of a problem. Reimbursement, no one's calling me on that.
Sometimes if I try to give ICSA, I may get a call. That is not supported by much data, but just the convenience. Mm-hmm. But yeah, I do dual maintenance in this patient and usually don't have a call from the insurance.
Okay, right. So the second case is an interesting case of amyloid submitted by Dr. Fox. Where is Dr. Fox? Thank you. Very interesting case. This is a 75-year-old gentleman who presents with a 2-year history of fatigue, some edema, neuropathy, and is just not feeling well, and has proteinuria. I presume this is non-selective proteinuria. It's 700 milligrams per 24 hours. He has a cardiac workup. His ejection fraction is normal by echo, but cardiac MRI suggests involvement by amyloid. So he has an abdominal fat pad aspiration, which was equivalent, and then subsequently has a kidney biopsy, which confirms AL amyloid, lambda light chain restricted, and involving the vessels. So he's referred to you. There's a discussion about high-dose chemotherapy with stem cell transplant. He's 73, and I guess probably wisely decided against it at that point. But so he's treated with 6 cycles of Cybor-D, tolerated it very well generally. He did develop increasing neuropathy, and so the bortezomib was eventually reduced in the last 2 cycles. His had a good response with a drop in his free light chains, and his BNP, brain-like natriuretic peptide, dropped into the normal range as well. So the question is, what do you do at this point?
I don't think I can do better than what's occurred. I mean, this is really a rather impressive improvement. The light chains essentially are normal. The cardiac biomarkers have improved. We have not, in our practice, used maintenance therapy for amyloid because it's such a low proliferative disorder. And he's 75. I'd probably pat you on the back and say, job well done. I think this is a good treatment, good outcome.
Agree.
Would you have used the same regimen, Cybor-D?
I would have.
Okay. So he's off treatment for 15 months, and then he's feeling better. He's able to walk a mile. Edema has improved. Now his creatinine is normal at 1.06. but now his BNP is rising a little bit, although it's still within the normal range. Other cardiac parameters are normal. He comes back to follow you, and the question he asks is, when do you think what would be the criteria for resuming therapy for his amyloid?
So yeah, I'd be concerned to see is, I would tell you that, and this will be coming out from us, that the free light chain ratio really is a crummy test for amyloid. It shouldn't be used. You might as well just look at the involved free light chain. You can look at the difference, but the involved is really the key. This is going to be a problem, and I think, is an indication for the resumption of therapy. Previous response to bortezomib would make me want to resume bortezomib. For patients who don't have much cardiac involvement, I'm looking again at IMiDs. We don't like using IMiDs and amyloid because the cardiac patients tolerate it so poorly. They really get sick from the IMiDs. But this patient doesn't have much cardiac, and I don't know if I wouldn't give a try of VRD and kind of hope that they tolerate it well. And if not, I can always go back to VCD. But that's kind of how I'd be looking at it. And keep in mind, DARA is really active in this disease. I mean, it's a really good drug, but it's unclear exactly where you put it into the therapeutic paradigm. But this is a patient who was unmaintained, 15 months, responded well, tolerated it okay. I'd be resuming bortezomib-based therapy with either cyclophosphamide or lenalidomide. And then when the next progression, or if this didn't work, toss in the DARA. Different people use DARA earlier, but it is just valuable to keep in mind that for this disease, DARA is a pretty hot drug.
But he hasn't gotten a mill transplant.
He was 75. I doubt that we would have considered him for a transplant. We worry about, they're not myeloma patients will do to 77 because these are patients with sick bone marrows and good organs. The amyloid patients all have good bone marrows and sick organs. And with albuminuria of 2, and if his serum albumin's low, they have a lot of risk of renal injury after melphalan. If he was 70, we would have done him for sure. We would have talked him into it. It's 15 months, so he's probably 76 and a half. I think the age is a very big deal with early cardiac and some renal, that would be unsafe.
Any other thoughts, Riley?
No, I agree.
Okay. All right. Next patient is submitted by Dr. Kumar. Thank you. So this is an elderly lady, 83-year-old woman, who presents with hypercalcemia, mild anemia, and an elevated serum protein level. A bone scan was done that was normal, and CT scans of the chest, abdomen, pelvis showed no signs of lymphoma or malignancy. She has an M protein spike of 4.3 grams, identified as an IgG lambda. A bone marrow biopsy confirms 90% involvement by plasma cells. She's actually hospitalized with pain from a lytic lesion in the sacrum. She lives independently, and other than pain, I think her performance status is good, although she is 83 years old, but she is able to live independently. She's now diagnosed with this myeloma, and the question is, which regimen would you recommend in this 83-year-old? Would you go with a 2-drug regimen or a VRD light, or what would be your thoughts?
Again, I think that hopefully she can be, made fit enough to get out of the hospital soon. There is obviously some pain that maybe she needs some radiation for, but if we can fix the calcium, there may not be as much urgency to start in the hospital in this patient as in the first one. And then optimally, I'd try to get her RD, but if for some reason I have to treat her in the hospital, I may give a 2-drug regimen of VD for a while.
I think that's a good summary. I mean, the overriding feature here is 83 and living independently. It will take next to nothing to put her into a nursing home for the rest of her life, so that when she gets out of the hospital, it's R15, D10, and then hope. Because we're not thinking about, gee, we need to get her to MRD negativity. you know? And if the calcium normalizes and the IgG goes down to 2,000, I'm going to have a good day. And so it's just going to be RD. But again, if she doesn't have a good response, I'll throw in some low-dose bortezomib after that. But you're right. Again, with this business about Len in the hospital is a headache. And so in a patient like that, it would be bortezomib dex in the hospital only. Not long. I'm very intolerant of keeping people on decks because they hate it, so then they end up hating me, and then everything that happens, it's my fault. And so decks, I mean, we do decks because it's not myelosuppressive, but it's clearly the drug every patient hates the most. And so anyone hits a plateau, the dex is coming down. But at this age, I wouldn't even give 20. I'd be nervous about it because, what'll happen, you're going to give it to her, and her calcium will be good, and her sugar will be 300, and then she'll start retaining fluid in her legs, and you've been there. And so it would be very, very short-lived, probably less than, it'd be 4 months and off dex probably if she's in plateau.
Maury, what do you consider the proper thromboprophylaxis?
So, no, I'm going to let Ravi do that one because when he's wrong, I'll tell you what's right.
Well, for this lady, I'd probably give a low dose aspirin. I think if we're going to put her on Revlimid, I think obviously there isn't any other. Am I missing something? Any previous history of thromboembolism or other high risk? Obviously, she's going to be a little less ambulatory than others, but the risk of probably bleeding from a full anticoagulation anyway. I don't think she needs it even.
I hate to say this, Ravi's right. So what type of anticoagulation? Now, aspirin is kind of weakish, and if you think about what is aspirin really supposed to do, it really prevents arterial thrombus. It really prevents platelet aggregation on arterial endothelium. So why do we use it for venous thrombosis? The answer is because all of the other options are so unpalatable. So look, you say, well, maybe I should give them warfarin. Okay, good. You give them warfarin while you're giving them Dex once a week, ciprofloxacin or levofloxacin, Bactrim, and do that, and you will get the INR between 1 and 10. It's a very, very difficult situation. Then you say, okay, well, am I going to put them on self-administered subcutaneous low molecular weight heparin for 4 months or 6 months? Patients despise it. The reimbursement is a nightmare, and it's really quite expensive, for which they'll have significant out-of-pocket. And then, of course, comes up the real question is, well, should you not have monopixaban, Deep down, I think that it might move that way, but the real issue is the DVT risk is what? It's 6%. What happens when you prophylax? It's 3%. So am I going to treat 94 patients in order to improve 3 patients? So I'm giving them aspirin. I don't think there's anything special about aspirin, but I'll treat the DVT when it comes, and it's aspirin for me too.
You mentioned about Levaquin and Bactrim prophylaxis. Kind of most of us, I don't think, have been doing that in communities, so that will be good too. But do you use it like with a triplet or doublet, or does it matter?
It doesn't matter. There's data that goes back 40 years about the early mortality, the number of patients who die the first 3 to 4 months with multiple myeloma, and what are they dying of? Very few are dying of renal failure, hypercalcemia. They're dying of sepsis. They get infected because their immune systems are garbage to begin with. Then you're giving a myelosuppressive or immune manipulating therapy. And so that's why I led off with that slide, because I was very, very impressed that they successfully, in a prospective randomized fashion, with 1,000 patients, used generic antibiotic and reduced the risk of infection. I think that's profound.
Okay. One final case. By Dr. Liu. Are you here? Okay, great. Help us if we need it. It's a 67-year-old gentleman, presents with back pain, muscle aches, some progressive weakness, found to be an acute renal failure. CT scan of the abdomen confirms lytic lesions diffusely in the skeleton. He has a kidney biopsy which shows capillary light chain deposition and Cass nephropathy. And a bone marrow biopsy confirms 60 to 70% infiltration by malignant plasma cells. He has a p53 deletion. He's treated with Velcade Dex for 3 cycles, but there's a marked progression and increase in his light chains. So therapy is changed to carfilzomib, that should be carfilzomib, pomalidomide Dex for 4 cycles. Initially, there's a transient response, but then an increase in the light chain, and bone marrow biopsy confirms persistent myeloma with 50% involvement. He was scheduled to undergo a transplant, but that's put on hold because of the findings. And therapy is changed to daratumumab, pomalidomide Dex for 2 cycles. And after that, his light chains normalized, and a bone marrow biopsy shows less than 1% plasma cells. He undergoes a transplant in February of this year, so about 4 months ago. He's currently on daratumumab maintenance. And the question is, is this a maintenance regimen you would recommend, and for how long? And what would you do when this patient relapses?
Well, I don't know.
A couple easy questions.
Yeah, so I think that again, this is a patient who's obviously blown through 1, 2 regimens, and then has a remission after a 3rd regimen. So I would say that in this patient, I would be as aggressive as possible for maintenance, and the patient does have a p53 as well. So I would try to maybe go with POM and DARA. Insurance, again, sometimes becomes an issue, but the fact is that we often, if they have had so much treatment, may be able to justify that, especially if they have a residual paraprotein. We say we're continuing treatment, is just not maintenance. We term it as, treating residual disease.
Yeah, I like that answer. I think that makes good sense to use DARA and POM. It's pretty obvious, even though it wasn't measured, this patient has a very high proliferative index. I mean, this isn't, theoretically, it's not going to last a long time. For a patient like this on maintenance, I'm already calling the CAR T center next door to find out if I can get them on the list, because you're going to have a problem. The maintenance, I agree. The question is, what are you going to do next? Barring CAR T, keep in mind that this patient has only seen 1 day of alkylating agents. And the patient got 1 day of melphalan for the transplant. And so the idea of cyclophosphamide or melphalan having a role here, you need to consider it. And you shouldn't forget about bendamustine, because bendamustine has activity in this disease, alkylator-like. And even though the patient's progged on POM, I don't see that the patient's progged on LEN. That's going backwards, I know. But the question of Bendadex or Bendalendex at relapse, if you can't get CAR T, is something I'd be rolling around. Valid. I mean, this is a hard thing. No one's going to say this patient's standard risk. And I feel if this patient was in Europe, the patient would have gotten a tandem transplant. And I think in the United States, I'm telling you, you'll go to 10 centers, you get 10 different answers for what. Would you do a tandem on him?
I would be tempted to, but he's 67. He's probably Medicare, and unless I say I'm doing a second transplant, which some people will do that, instead of taking it as a tandem, they'll just say we're doing a second transplant. I don't try to, mess around with Medicare, so I wouldn't be able to transplant him even if I wanted.
Well, great. We're on time, and a very good discussion. It shows you what the